I, Dr. R. Purnima, Assistant Professor of Department of Obstetrics and Gynaecology in Venkateswara Homoeopathic Medical College and Hospital, take on my behalf of my OBG department, I take immense pleasure in welcoming our MD, Engineer Mr. Subramani sir, our Principal Dr. Shakuntala ma'am, our Trustee Member Mrs. Padmavati ma'am, who is Associate Professor, the Department of Obstetrics and Gynaecology in Sri Ramachandra University. Welcome ma'am to our VHMC family. I am extremely happy to have you here in spite of your very busy schedule, and it's a great honor for having you here ma'am. And before we start the session, I would like to introduce our honorable speaker of the day, Dr. Preet Agarwal ma'am. She started her career as lecturer in OBG department at TN Medical College, Mumbai in the year 1999, and then she was the registrar in OBG department at Women's and Children Hospital in South Australia. And in 2004, she was the registrar in Obstetrics and Gynaecology department at Auckland Hospital in Auckland, New Zealand. And then she moved to India and she joined Sri Ramachandra University as assistant professor, and currently she is the associate professor of OBG department in Sri Ramachandra University. So her career starts from 1999, almost a span of almost 20 years from now. So she has authored great this 20 years, and you're going great, and many more years to come. She is one of the leading obstetrics and gynecologists in Chennai. She is well known for her delivery skills and everything. She has authored many books and journals and presentations also. I would like to mention a few of them here. She has authored Triplet Pregnancy with Partial Hydatidform Mole, Sigmoid Volvulus in Pregnancy, an Uncommon Case of Amniotic Band Syndrome, Broad Ligament Pregnancy, Cervical Pregnancy, a Diagnostic Dilemma, and the list goes on and on. And I am not taking much of your time, of your valuable time, so let's dive into today's webinar. Ma'am, over to you for session 1, ma'am. Dr. Preet, ma'am, over to you.
Good morning, one and all. Thank you, Dr. Purnima, for the wonderful introduction. I would like to, if you allow me to share the screen for you. Just put on the screen sharing so that I can put on my slides.
Dr. Mithun sir, can you please help Dr. Preet, ma'am?
Yeah, like the permission has already been granted, ma'am. Like you can directly share it now. The permission has already been granted.
Yeah, how do I go about it, sir?
Ma'am, there'll be, just a second, ma'am. There'll be one share option at the lower end of your screen.
Yeah, now only it has come.
Okay, ma'am. So you can click that and share your screen. Ma'am, your screen is visible now, but your voice is not audible now, ma'am.
Sir, can you hear me now?
Yeah. It's clear, ma'am. Your voice is clear now. We are also able to look at your screen. The screen is also visible.
Good morning, one and all. I am Dr. Preet Agarwal, is going to speak to you about the evaluation of an infertile couple. Now I've got an audience from first year to the interns to the senior people, so I hope I do justice to the topic. So we start. How will you evaluate an infertile couple? This is the most common type of gynec population which comes to our OPD. It constitutes about 10% of our practice. And when the couple comes to us, they are very anxious and they want to have the baby as soon as possible. The rate of pregnancy being the marriage age going up, and the ladies working, professional ladies. So there are chances that the couple gets very stressed out and comes to you. So here I'm going to make you go through the journey of first to find out what is the cause of infertility and how will you evaluate a male and a female partner. Now as we know that infertility is a disease defined as a failure to achieve successful pregnancy after 12 months or more of regular unprotected intercourse. As we all know, a couple will conceive, around 57% of the couples will conceive in around 3 months of time. And in
ma'am, just a second. Sorry to interrupt. Ma'am, your PPT is not visible, ma'am. Your desktop is only visible right now.
PPT is not visible, sir. Why?
Yes, ma'am. Like only your desktop is visible. Your laptop's desktop is only visible.
So what's wrong? The teaching problem. Now can you see, sir? Sir, can you see now? Sir, can you see now? Teaching problem. Sir, can you see now?
No, ma'am. It's not visible, ma'am.
Just hold on, I'll try again, but it is okay.
Ma'am, am I audible, ma'am?
Mithun sir, yes, you are audible.
Okay, I'll just contact Preet, ma'am.
Mithun sir has given Dr. Preet Agarwal ma'am's number in your WhatsApp.
Okay, ma'am, like your screen is actually fully blank now, like it's a white screen right now. Yeah. Okay. Okay. Just a second. You have to take the chat and then you have to select that specific PowerPoint which you want to present.
Yeah, I clicked on the PowerPoint, sir.
Okay.
Can you see now? You allow me screen sharing? Yeah.
कंप्यूटर इसका प्रॉब्लम हो रहा है यहाँ पे इंटरनेट में इसको प्रॉब्लम चार्ज हो गया उधर बैठो
पीछे का था हेलो Yes, sir. What is the problem, sir? Sure, sir. No problem. You take your time. Insulin.
Preet ma'am இருக்காங்க பாருங்க. இல்லையா? அவங்க ஃபோன் காங்க ஒரு நிமிஷம். Hello? Yeah, ma'am. Ma'am, this is Dr. Mithun, ma'am. Yeah, ma'am, like, you have logged into this thing, ma'am, this thing, the doctor, like, you're, okay, but, this thing is not, visible right now, ma'am.
Yeah, I've gone to the desktop. Start sharing about.
Yeah.
Okay.
And yeah, it's getting loaded.
Now you can see my PowerPoint.
Your
Now the screen has gone blank.
yeah, it's not right now. Like your video is right now PowerPoint.
Now can you see my screen?
Your screen is visible, but your can you please open the PowerPoint up?
Yeah, PowerPoint is open, sir. Tell me. Yeah.
Or a pre-concept call app.
Sir, tell me again.
Yeah, open the pre-concept call app.
Please answer, yeah, open.
Yeah, you have click the share option.
Share option, click.
Yeah, what are the options which are showing over there, ma'am?
Nothing is coming screen. Wait 1 minute.
There will be 3 to 4 options over there, ma'am. Like whether to allow permission to only the application, the PowerPoint alone, or the whole screen.
That already came. I put on the desktop.
No, ma'am. You go to the PowerPoint option alone.
Oh.
Okay, I'll go to the. Allow me screen sharing again.
Like, yeah, I'll give logged in, right?
Yeah, I've logged in.
Yeah, I give it the function. Yeah, I made it right now.
Yeah. I'll go to the Microsoft PowerPoint only, huh?
Yeah.
The 3 options are, one is desktop, infertility, Microsoft PowerPoint. So should I go infertility? Oh, yeah. Again, this sir. Again, give me slide sharing.
Yeah, just a second.
Because among that, I've kept it on the desktop open.
Okay, yeah, that is the right method, ma'am. So I've given the you can control over the sharing of it.
Give me share. Again, give me share.
Yeah, I made it open. Select the share option.
It's not come. Just wait. No, it has not come. No, it has not come, sir. For me, audio, visual, everything is on. Yeah, now it is coming, I think. Yeah. Then I'll go to the infertility thing. Huh?
Yeah.
Okay.
So getting chat box.
Online meeting है होता है. Shall I start sharing pictures? Hello.
Yeah, fine. It's loaded now.
But I'm not able to see it.
Pusha, can I start a Zoom meeting and I'll send you the link and we'll start with that.
यहाँ पे चेक करना है ना. Sir, this conference call is not working. Can we go to Zoom or something? I can give you a link. Because it's taking so much time. I've been trying from yesterday. It is not coming at all.
Ma'am, one small thing you can do, ma'am.
Yeah.
Can you mail this thing, the PowerPoint to me? I will present it, ma'am. Because your video and audio everything is clear.
But if I give you the PowerPoint, how will I regulate it? I only have to regulate it, no sir?
Yeah, that's fine.
अभी क्या करना है? So I'm clicking on the share. Okay.
Ma'am, last time, can we do one thing, ma'am?
Yeah, tell me, sir.
You please log out from this session, this pre-conference call, you please log out from this session.
Leave.
And yes, ma'am. You log in through the ID which I am telling you, ma'am.
Okay, just hold
I
on.
think it will be good. Yeah.
So leave? Yeah, you are leaving?
Yeah.
Yes.
You just leave.
Immediately go for the investigation. And even in the younger couples like 22, 23, 24 years old, if there's history of irregular cycles, or if there are known case of any uterine problems like they have a fibroid uterus or they have an endometriosis or anything, or when we are having the suspected male factor something can be there, then always start to investigate earlier. So this is when we start investigating a couple. Now, the investigation of the couple does not depend upon the male age, it depends on the partner's age. This person will have this much of, she will consider everybody doesn't have the same rate. Each person has a particular number of follicles at birth. And as it goes on, the fertility is between 18 to 31 and the fertility reduces after 31 years of age. So that is why we are worried that the age is very important when they come to us for the checkups. Now, as we know, the factors contributing to infertility, male and female are equally responsible. That male factor is around 40%, even female is responsible to around 40% of the infertile couple. Sometimes we get couple where the mother-in-law brings the daughter-in-law or the mother brings the daughter for it. No. Infertility always is a couple sitting together and we are talking to them together. No seeing the individual separately. And as we know, the combined factors will be 10% and 10% will be unexplained variety. So out of the female factors which constitute around 40% of the cases, ovulatory disorders, that is the polycystic ovary, irregular ovulation problems constitutes 30%, where the tubes and the tubal motility constitutes around 25%, and we have the others variety which I will be telling you, and unexplained, everything will be normal. This is the most important, the most difficult part of the treatment, where we see that the husband is count is fine, wife is ovulating, tubes, ovaries, everything is fine, but still they are not able to conceive. This variety is more difficult to treat. Okay. Then always remember that the evaluation of both partners should begin at the same time. It is not like that you will start with the female first or the male first, like that. Not like that. Both the evaluation of both the male and the female partner should be started at the same time. For male it is easy. Just do a semen analysis, less invasive, and if his count is normal and there is no history of any coital problems, then we can directly go ahead with the female. But always remember, before starting the male partner's evaluation, female partner's evaluation, we should be sure about the male partner's status. Now, how do we evaluate a female partner? This is very important. Here comes our role. Here comes where we sit and decide which patient requires what treatment and which person we have to go for what. You cannot just say that the person has come, we will give a set of investigation, we'll ask her to do this. No, we have to individualize that. And if we take a good history and examination and investigation according to the history and the examination, we will definitely be able to click. So I am going to tell you about how we are going to take the history of the patient, how we are going to examine, and what investigation should we order for them. Coming to the history, always whether how long they are married for, how long the couple has been usually trying to conceive. We will have patients where the husband will be somewhere abroad and he comes for a checkup for just 1 month, or he is there for 6 months here, and the couple gets very anxious and they come and tell us, look doctor, we are trying for the conceiving, but when we take a detailed history, they have not been together, and our definition of infertility has not gone. They are not together for 1 year or so. They would have been hardly 1 month, 2 months alternate time, and that may not be the time for when they are when it is a fertile period. They may be together in the beginning of cycle or the end of the cycle. So here you have to sit and talk to them and find out what the couple has been actually trying to, how long they have been trying to. Sometimes they will have one baby and they have been trying for the second one just recently, and they would have had a copper T inserted and they would have forgotten about that. Many a time it happens like that, especially in this hospital where they put the copper T and the couple does not know about it. And the contraceptive usage is very important. And of course the menstrual cycle gives us a very clear idea whether the female is ovulating or not. And the regularity of the cycles, the duration of flow, the mid-cycle pain called the Mittelsmith pain of ovulation, and the types of dysmenorrhea, whether she is having pain during her cycle. If she is having pain during the first day of the cycle, it most commonly indicates ovulatory cycle. But if she is having pain prior to the periods, that is called the congestive dysmenorrhea. She says, doctor, I am having severe pain, and when I get my periods, the pain goes away. This is the time where we have to evaluate for pelvic inflammatory disease, endometriosis, fibroid uterus, adenomyosis. So these all have to know, and how much is the severity of the dysmenorrhea. Okay. Whether she is having history of dyspareunia is there or not, how frequently they are together. Sometimes they will be together once a month, twice a month, we don't know. We have to educate them about the fertile period and whether they are using any lubricants or not, and whether she had any previous spontaneous conception method or she had a previous treatment also. The history is very important. Any medical problem she has got, any previous, any smoking, alcohol, job, IT people. Family history of infertility is also there. Her sister has also infertility problem. Her aunt has, her mother has, and the polycystic ovarian thyroid disease. This all runs in family. So we have to have a good idea about the infertility family history status. After that, we come back to the examination. Height and weight is very, very important. Sudden gain in weight, sudden gain in weight, newly married. She would have lost weight to look pretty during the wedding. And then what happens? the periods were regular prior to getting married because she has lost weight. And suddenly after marriage, she puts on some 7-8 kgs. And then she comes to us, doctor, my periods were regular. They are not trying to tell us. They are trying to hide us that they had definitely reduced weight to get the regular cycles, because they feel bad in front of the newly married mother, in-laws and all, to tell us that yes, she had irregular periods prior to cycle. But if you sit with her separately, sometimes what happens, though the couple comes to us, we have to sit separately with the female and separately with the male partners, and together get out so many things which we are not able to. So BMI, the waist, height, weight, the ratio between the waist and hip. Why the waist is important? Because when a female puts on weight, it is the tummy fat which is first to come. And this fat contains adipose tissues which convert the estradiol present in the fat to the testosterone, and that causes the acne formation, balding and voice change and all that, and that also causes anovulation. Thyroid routinely we examine, and we see always the breast has to be examined. Don't leave it very lightly. There may be galactoria, though sometimes the prolactin level will be normal. We can get galactoria there, that is the secretion from the breast milk, from the breast nipples. Always look out whether she's got hirsutism, any signs of balding is there. These are all telling that there is androgen excess. And acanthosis nigrans, that is the blackish patches on the thing. The stria is there. Stria says that she's gained weight suddenly. Okay, and the buffalo hump is there. This all tells us about the gaining weight and the other signs of androgen excess. Then apart from it, we have to examine the tummy. There may be a big mass there. Sometimes you'll be surprised. As soon as you put your hand on the tummy, you can feel a palpable fibroid there, which she did not have any symptoms previously. She may be having a financial scar or any scar of a previous appendectomy done or a previous ovarian cyst removed, which she may be hiding from the family. So when you see the scar or mass, don't immediately tell her on the face with the husband there. Maybe she's trying not to tell them. Just gently tell her, the scar there is there, are you aware of it? Then she may give you some indication she doesn't want to tell. But if she is telling us, he is open with it, then you can sit and discuss with them. Apart from that, you have to do a local examination. Sometimes you'll be surprised that the hymen will be intact. They will not be knowing how to have this intercourse. There you'll be surprised. But yes, then when you talk to her, you will know that she may be having vaginismus, she may not be knowing the act. That also helps us. A lot of information with heart couples like that. Any sort of infection is there, any white discharge is there, chlamydial infections is there. You can see a septum over there, anatomical abnormalities are there. And when you do a bimanual examination, you can see the uterus, how big it is, any adnexal mass is there, and uterosacral nodularity, which indicates endometriosis, is also there. So apart from the history, a good examination gives us the clue as to where to start from. And without investigation, we start with usually a transvaginal ultrasound is a must for all the infertile couples, because it tells us about the uterus, how it is. It also tells us about the ovaries. Tubes, of course, they will not be able to know, and ideally we should do it on the day 2 or day 3 of the menstrual cycle. You'll be thinking why we should do so early, she'll be having the menstruation, how can we do? But that is the time where we can do, along with the scan, along with knowing the condition of the uterus and the ovaries. We can also know about the antral count, antral follicle count, which I'll be telling you in a detail, which is very, very important. Okay. Then we can see any cyst is there, because if you see a cyst in the later past, it will be a follicle. But on day 2 or day 3 of cycle, we can see a cyst and sliding scale, and when we put the vaginal probe, the ovaries will move apart. That says that they are not stuck to the pouch of Douglas. But if the ovaries are not moving apart, the sliding sign will be negative. That will tell us a small degree of endometriosis there. And to see any fluid in the pouch of Douglas for cases of PID. So ultrasound, especially the transvaginal ultrasound, is a very important marker, and it helps us around the infertility quite a bit. So the place of scan should be very good, where they are able to do us and tell us the position. Sometimes the uterus will be very retroverted because of dilations in the pouch of Douglas, and it will give us a lot of idea about the volume of the ovaries, which was the hint of the polycystic ovaries. Apart from that, we have the, once we come to the normal transvaginal ultrasound, we can also go for the 3D ultrasound, which will help us to know the uterine anomalies like the bicornate uterus or the arcuate uterus or the uterus diabetes, and also helps in mapping the fibroids if it is whether encroaching into the cavity or not. All fibroids need not undergo myomectomy. Only those fibroids which are encroaching the cavity are the causes of infertility. Okay, and the Doppler and the MRI higher investigation, where we have to know about the intra and blood flow and the follicular study, and go for the adnexal pathology where we have doubt about the diagnosis on the transvaginal ultrasound. Now coming to the laboratory investigation, I have gone through the history, I went through the ultrasound, very important examination. Now we come to the laboratory investigation. Routinely we will do the hemoglobin, the sugar we have to rule out, and the HIV and HbA1c status of all the partners. Apart from that hormonal assay. Is it required for all the infertile patients? No, it is not required for all the infertile patients. We have to know which hormones to give to which type of patients. If she's got menstrual irregularities, irregular cycle, oligomenorrhea, hypomenorrhea, anovulation, galactorrhea is there, then we'll advise her to go for the free T4 and TSH. You did not do T3. You will do T4 and TSH along with the prolactin level. But if she's got along with this irregularities, anovulation, galactorrhea, you have some degree of hirsutism in her, some moustache is there, something is there, hoarseness of voice, acne is lot of there. Then along with it, you can advise her serum, total testosterone level. Okay, but if she's got, when we come to the things that she may be a polycystic ovary because of the criteria she's got, then we can, along with that, we can use with the rotten. We do not do the FSH-LH level. Remember that we do not use FSH-LH level for diagnosis of polycystic ovary. Polycystic ovary is diagnosed by the Rotterdam's criteria. That is, there are two or more of the three criteria. That means it can be a clinical as well as a biochemical, or it can be a scan finding. Alone scan finding with no signs of anovulation and clinical and biochemical signs is not polycystic ovary. So remember, for all polycystic ovary, we do not do the FSH-LH level routinely. Okay. So if you have they are not ovulating, irregular cycles are there. On the scan, we find that they have got more than 10 follicles around, or if there is any sign of hyperandrogenism, increased testosterone is there, the level is there, or she's got hirsutism along with irregular cycle, that also tells she has got polycystic ovary. So polycystic ovary is not the diagnosis of the scan. Sometimes the scan will tell that she'll be having regular cycles and she doesn't have any signs of hirsutism or any other thing. Then we cannot tell. So to tell our diagnosis of polycystic ovary, we have to strictly follow the Rotterdam's criteria. Now the question comes, is the thyroid function necessary for all infertile women? Yeah, definitely, because subclinical hypothyroidism is there is a guideline seen in the Fertility and Sterility Journal which states that the subclinical hypothyroidism in infertile population is there and we have to treat them. Now, which patients do we treat? The current evidence says that routine testing of TSH is required for the infertile women. Okay, and if the TSH is more than 4 milli-international units per liter, then only we have to treat them with thyroxine, and our aim is to maintain it below 2.5 milli-international unit. But if the TSH is between 2.5 to 4 milli-international units, then we have to just monitor at regular intervals, repeat after 3 months or 6 months. If at all required, now the TPO antibodies again have got controversy. Previously we were doing the TPO antibodies, and if it was positive, then we were treating even the people with less than 4 milli-international units. Now again the latest study says we need not do the TPO, we just repeat the TSH after 3 months. Now, whenever a person comes to us, they have gone through so many doctors. Always remember, whether they have come to you for the first time, whether they are newly married or not, or whether they have gone through doctors and doctors changing and all. Files. Never think that this is a waste of time to sit with them and go through all the files. It is always important that we go through the previous studies, previous records of the patient, because people believe they'll try 2 months in one doctor, then go to another doctor, then they'll go to another doctor. So in the long run, it is missed out, and every person who sees them the first time, start treating them again from the beginning. Don't do that. take out all the old files, sit and see them, where exactly the problem starts, and then start treating them. And suppose if she's gone through many cycles of ovulation induction, irregular cycles, like some 10-15 cycles of ovulation induction, she's more than 35 years old, or whether if you feel that she's got a low reserve, then we have to go for tests for ovarian reserve. As we know, she's elderly, then definitely you have to go. Now, what are the tests for ovarian reserve? As I told you in the beginning, that each female is born with certain amount of follicle that cannot be changed. It is like a bank balance. You have got it. Okay. It is that around when you are ovulating, you are using one of your follicle. So some people, if they are ovulating many times, will have very less reserve, especially when we do ovulation induction. We take so many follicles at the same time. So if she has undergone all that, always remember we have to test the ovarian reserve, because the female has got a very small reserve at the moment. You have to immediately go to higher level, either to IUI or ART, instead of wasting time with her, and we have to refer her fast to the specialist in that. So how do we do that? We do an ultrasound where we know the ovarian volume. We do something called the antral follicle count, which you, if you are doing a level 1 scan, can also count on the day 2 or day 3 of cycle, and by doing a test called the FSH, LH and Estradiol and the AMH, that is the anti-mullerian hormone. Now, why do we do ovarian testing? It predicts those patients who are at risk of decreased ovarian reserve. And if there is decreased ovarian reserve, when we try ovulation stimulation, more follicle will be formed, and there is reduced probability of achieving a live birth in a single reproductive cycle. And this, knowing the ovarian reserve, helps us to advise aggressive fertility treatment, so that we do not waste, we know that we cannot stop the biological clock of the female, so we can directly go for IUI or the ART procedure instead of wasting and going time for the expectant management. Now, how do we do the follicle count? Here, see, this is a picture showing the polycystic ovary, where there are more than 10 antral follicles there on the day 2 of cycle. Usually 4 to 6 antral follicles are enough. So any follicle which is less than 10 millimeters is called the antral follicle. If it is more than 10 millimeter size on day 2 scan, it is not an antral follicle. So if a lady has got 4 to 6 antral follicles, the reserve is good. If she has got more than 10 antral follicles, then the diagnosis of polycystic ovary comes. And then we have the treatment go separately. And if you've got 1 or 2 antral follicles, it says poor ovarian reserve. Then we have to go to the other hormonal assays. So who are the candidates for going the hormonal assay to go after doing the baseline scan? Those people with amenorrhea, and they say that, doctor, I get periods only when I take my tablets. I get a period when I take my tablets, and that too also takes a very long time to get the withdrawal bleed. And they are elderly, or they have got a previous history of ovulatory done for any ovarian cyst, and any pelvic surgery done, and if she has got any history of chemotherapy, radiation, or she has or any person who is going for the artificial reproductive technique has to know the ovarian reserve by doing a hormonal test. Now, what is the hormonal test we know for the ovarian reserve? On day 2 of day 5, we do the FSH and estradiol level along with FSH, or if you don't have the menstrual cycle, you can go for the AMH, that is the anti-mullerian hormone. Now, what is the importance of the baseline FSH and estradiol? Remember, if the FSH value is more than 10 milli-international unit on the day 2 of cycle, you remember the menstrual cycle, the FSH is low, then slowly goes up, the follicular stimulating hormones, they stimulate a lot of follicles, and after the follicles are stimulated, they come and then they ovulate, there is secretion of LH surge and there is ovulation there. And this FSH, the antral follicles also secrete the estradiol. So if you have more than 10 milli-international on the day 2 of cycle, it says that they are poor responders. They are going towards perimenopausal. The reserve is very poor. And always FSH should be interpreted along with the estradiol level. Many times we see prescription where the patients are given FSH LH level. Remember, FSH LH level has got no value if not given along with E2 or estradiol. So you change your prescription to FSH LH E2 rather than only FSH and LH. Now this estradiol level on day 2, if it is high, that is, it is more than 60 to 80, less than 60 is normal, less than 30 is reduced. So if it is more than 60 on day 2, it says what? there is accelerated follicular development due to decreased ovary reserve, and this will stimulate the serum estradiol levels. That means there is poor reserve. If on day 2 we see very high level of estradiols. Then similarly, the alone estradiol should not be used for the diagnosis of the decreased ovarian reserve along with FSH. So this is an important point. If FSH is normal and the estradiol is high, then remember, in the absence of any cyst, then remember there is a decreased reserve. But if the FSH is high without the estradiol value, menopause, okay, or the reserve is poor, is going dating. So always remember, if FSH is normal, that is less than 10, estradiol level is very high, but the ovaries are not having polycystic ovary, then the decreased reserve and high risk of poor response. But if the ovary is showing polycystic ovary with increased estradiol, it is a diagnosis of polycystic ovary. Now coming to the AMH is secreted from the anti-Mullerian hormone, is secreted from the antral follicles and can be done in any part of the menstrual cycle. Okay. This is how you see the AMH value is throughout the cycle is absolutely the same. And the AMH begins at the age of 15, it begins to be 3, and more than 2 is considered to be normal. So normal ovarian reserve is more than 2 nanogram, and if it is the poor reserve is if you get an AMH of around less than 1.1. Why we have seen? Because if the AMH is less than 0.7, the chances of them to have a live birth rate is only 15. So that is the value of AMH. When a couple comes to you with a normal uterus, normal tubes, normal ovary, and husband count should be normal with a normal cervical factor to compute. Okay. So this is how the requirement for the normal fertilization. Now before you know how to know the tests of ovulation, as you know the ovulatory dysfunction accounts for about 40% of the female infertility. So we have to know about the ovulatory dysfunction. And one more thing I want to stress on, if the female is having regular cycle does not mean she is ovulating. Because 1% of the regular cycles are anovulatory. Remember that. Children that are having regular cycle does not guarantee ovulation, and a female does not ovulate every cycle. Sometimes she'll be ovulating continuously for 3 months, sometimes alternate months, sometimes she'll be ovulating once in 3 months. So we have to know when she's ovulating. Of course, we can't do the basal body temperature to confirm the ovulation, but this does not predict ovulation. This does not predict ovulation. This tells us that after ovulation has come, we can tell yes, she is ovulated or not. Then we can do nowadays the LH kit is available, where we can do the LH kit to start doing it. Okay, so twice a day or once a day, from 11th day onwards. But and this goes more than 40 international units. That means it comes, the 2 line comes. That means the ovulation can occur 2 days anytime at that time. But there are disadvantages, as there are false positive and blissful areas that yes, I had ovulated of around 7% chances are there. Then another test is there where we can know the serum progesterone. Usually serum progesterone helps in a 28-day cycle. And if you do serum progesterone on day 21 cycle, because you're not sure, you're doing the follicular monitoring, suddenly you see that the follicle has not collapsed. There may be a corpus, what you call neutral unruptured follicle will be there. So we are not know whether she is ovulated or not. So how do we tell whether we have done the IUI? We don't know. We are not very sure. So we can do one small test to know is by doing the serum progesterone level. Or whether she was doing the follicular monitoring and suddenly she disappears, does not go on the time when she has to go. Or there are 2 people doing the follicular monitoring, whether the single person is not there. So on those cases, if you do on day 21 of a regular cycle of serum progesterone level, if it is more than 3 nanogram per ml, it indicates ovulation. But as you know, the disadvantages are there if she's got irregular cycle, and there is a pulsatile secretion from the corpus luteum of the progesterone level. But the most diagnostic thing for the test for ovulation is a transvaginal scan, where we are doing the follicular monitoring and we see that there is a sudden collapse of the follicle, or the follicle becomes irregular in size, and there are internal echoes. Sometimes it will not be there, the follicle will be internal echoes. That also indicates ovulation, and definitely presence of fluid in the pouch of Douglas also indicates. And suppose sometimes we will not be able to find any of these signs, then we can see by putting a color Doppler around where we see the fall in the resistance index and the peak systolic velocity in the Doppler ultrasound. Then after we have evaluated her ovulation status, we come back to the tubal status, because as I told you, the tubal factors are responsible for 25% of the population. So when the couple comes to us and we see that she's got regular cycles, she's ovulating, and we have done the husband's count, it is absolutely fine. But she's got a previous history of tuberculosis, or previous history of any white discharge or any chlamydia infection, always better to test the tubal status. Or if she's come to us after 35 years, then we do not wait the criteria of 1 year's time. We quickly go ahead and start doing the tubal status. And the very easy, less invasive thing is by doing the HSG. As we know how to do the HSG, always remember HSG is done in the first 10 days of a cycle. That is the rule of 10 for X-ray. We do not do HSG after the 10th day of the menstrual cycle, because in case she is ovulated, there is a chance of the baby being exposed to the radiation. And we do not do when she is menstruating. We wait for the menstrual bleeding to reduce or to stop, because when you push the dye through it, there is a chance of the endometrium going out, and there can be chance of endometriosis. That is the implantation theory. So now the advantage of this HSG is you can know the status of the uterus also along with the tube. So if you know the status, we can find out the bicornate uterus, unicornate uterus, or cervical incompetence also we can find out where there will be funneling over there. So it is, how do you do it? The patient comes to you, it's given an atropine and buscopan, give them pendulum, put a Leach Wilkinson cannula here and push out the dye called the meglumine dye, or the dye that is iodine dye, and always remember it has to be done in a setup where there is first aid is available, because many a time we see the ladies are, there is a hypersensitive to the iodine dye. We have had history of places where they get so much allergic to the iodine dye that death can also occur. So we should have the hydrocortisone and everything that they cart ready before doing an HSG. It may sound a very small procedure, but there are chances of going into vasovagal syncope and even going for the dye reaction. So always remember, a first aid kit should always be there, a cart should be there with steroid and all that. So we don't know which patient will be allergic, though it is very, very rare, but it is very important. That's why I'm stressing on that. And we should always give antibiotic, that is doxycycline, to prevent the post-exposure infection of chlamydia, especially because they are not routinely screening for chlamydia. So we give them a doxycycline a day prior and continue 100 mg twice daily for 5 days. Okay, when we do a HSG. So conclusions of female is, without proper history and examination, do not give any medication just like that. Okay, we take this tablet, you will conceive, or give any, what they call so many other tablets, vitamins and all that. Don't treat the partner, and always remember, do not treat the female partner without doing the semen analysis. And one more thing is, we always tell them, okay, this 8 to 18th day is the time you ovulate, so you have to be correctly on this time. Don't give them advice for timed intercourse. Just tell them to be naturally at least 2 to 3 times per week. That increases a lot of stress for them. And always remember, do not waste time during treatment. As you know, that there is continuous fall in the number of oocytes as the woman age advantage. Remember, biological clock is the woman is clicking. So do not waste time. If you are not able to do it, send it to the other special person. When that person can't do it, can always refer to the other person, because our aim is to get her pregnant. Our aim is not to prove ourselves whether we can cause the pregnancy and all, because every female is different. Now in short about the male infertility, we come to, as we already told you, male constitutes around 30% of the combined effect of the infertile couple, and then we have seen that who are the people. The male age is not important. He may be a 40-year-old, 60-year-old, doesn't matter. But if the female is more than 35 years old and they have been together after 6 months, do a male semen analysis. And we always ask whether the male is about the future fertility, is having the concern about future fertility, then we start evaluating the males. Otherwise, we usually wait for 12 months. Now coming to the anatomy, where you all know how the seminal fluid is secreted, it starts with the sperms are secreted from the testes, and then they go into the vas deferens. Okay, then they come through the vas deferens. From the seminal fluid, the fructose comes. From the prostatic fluid, the volume comes, and then they come and they get ejaculated here. So this is how it is, the anatomy of the male gonads. So the 2/3 of the ejaculate is from the seminal vesicle. Okay, and that is secrete the fructose. So many a times when we do for semen analysis, we see absent fructose, we know that there is some obstetric problem there. And it also gives the pH to the seminal fluid, the vesicle gives the pH to the sperm, to the semen, and the prostatic constitutes about 1/3 of the ejaculate and gives the proteolytic enzymes which helps the what we call the viscosities to be reduced, and the sperm itself causes only about 1 to 2% of the ejaculate. So this is how it is secreted. The LH comes and stimulates the Leydig cell. The Leydig cell secretes the testosterone, and this testosterone goes and stimulates the Sertoli cells of the testis, and which causes the spermatogenesis. This is how the spermatogenesis occurs. Now the male problem can be in the pre-testicular. That means it is something to do with the hormones, or it can be testicular problem. That is in the testes it can be, or it can be the post-testicular problem. Now coming to the pre-testicular problems. Hypogonadism, hypogonadism, it can be some Kalamin syndrome, where you know there is a problem with the chromosomes. Testicular, it could be cryptochrome, varicose cancers, azoospermia, any problem with the environmental factor, testicular injuries, anything can cause testicular. And post-testicular can be some problem with the vas deferens, either it will be absent or there is vasectomy done and vasectomy reversal done, any injuries, or medication, where the ejaculation problem is there, or resection, they would have had a prostatectomy done. These are the problems with the different types of male. Evaluation of the male history. Male starts again with the reproductive history. Sometimes it will be a second marriage for them. You can always ask them whether they have had any children with the first one, and along with the semen analysis. Now social history, always ask them whether they are smoking, drinking, because smoking and drinking has associated with low count for the males, and whether they are working in hot temperatures, okay, and working as a welding person and all, where they are exposed to the high temperature, and where they are using any steroids or cocaine or marijuana they are using. Always set and ask to them separately from the female partner, so that they will be able to tell you the truth. In any time they will not tell you when the female is sitting with them. An examination, do we do an examination of all the male partners? No, definitely we do not do. We do only when they have the coital problems, they have pain during intercourse, or they have history of surgery. If the count is normal, no history of any coital problems are there, no need to examine the male partner. Now what are the things we do for the male partner? As I told you, semen analysis itself clears all the problems. Only when the semen analysis has some any problems, we go to the hormonal evaluation, or the genetic evaluation, or the sperm function test we go to. Now coming to the semen analysis. The reproductive history is important. At least one semen sample should be there, and if the initial evaluation is abnormal, then complete evaluation of the male partner is recommended. Semen analysis, always remember abstinence of around 2 to 5 days should be there. They should not have an abstinence for more than 10 days and all that, or they should not. But if you have a previous history of oligospermia, even abstinence for 1 day should be okay. And always it should be either collected in the nearby the laboratory or in the laboratory, and should reach the laboratory within 1 hour of collection. And one reading abnormal is not abnormal. Minimum of 2 readings should be abnormal, and this is the WHO criteria, strict procedures criteria, where we say the volume of should be more than 1.5, pH should be 7.2, and at least 15 million sperm should be there per ml. Okay, motility should be 40%, vitality should be around 60%, or you can take it as 50%, and the agglutination should be absent. There should be morphology, only 4% is normal. Morphology includes the head, acrosomal cap, and the tail. If it is normal, 4% according to strict previous criteria is enough, and viscosity should be less than 2 centimeters, and there should be no pus cells there. If more than 5% is there for high pain, you should always treat them if the count is less, or go for the checkup for the diabetes for them. So don't read the final impression. Always from the lab it will come. Oligoteratozoospermia, normal study. It is not normal. You should go to each value, because each value will tell us what is the problem. So if the volume may be less, but the count may be more, motility will be more. No, if the volume is less than 1.5 ml, always see whether she is having any retrograde ejaculation is there or not, or any erectile dysfunction is there or not. pH is less, then we should always think the erectile dysfunction, or when there is a seminal vesicle is absent. So fructose is absent. As I told you, fructose comes from the seminal vesicle, and the alkaline pH comes from the seminal vesicle fluid. So always these two, if the pH is less and the it is acidic, it will kill all the sperms. Okay, motility will be less. And fructose is absent also tells us that is the nutrition for the sperms. And prolonged lutefaction sometimes, as I told you, the proteolytic enzymes come from the prostate. So there will be pure prostatic secretion will be there. And there is blood in the sperm. There may be TB, tumors, infection. So go by each value. Don't read by the final impression what is written at the end. And always do the semi-analysis from a standardized lab. Okay. Hello? Can you hear me?
Yes, ma'am.
Yeah, sorry, I got some other voice. Yeah. Always do from a standardized laboratory, and always remember, one report is not abnormal. If you say that one report is normal, don't get worried. Counsel the couple, be cool, and repeat it again after 2 to 4 weeks apart. And p-values abnormal will only tell it is abnormal. These are the few definitions for completion: oligospermia, teratozoospermia, asteno means motility, aspermia means total ejaculation is absent, necrospermia means lot of dead sperms will be there. Now, do we do the endocrine evaluation? That we have done the semi-analysis, it is normal. Only when the count is less than 10 million, or there is impaired sexual function, or any other endocrinopathy is suggested, then only we go for endocrine evaluation of the male partner. Now, what do we do? Mainly the FSH and the testosterone. If you see the count is less, okay, repeat again the count is less, then we have to find out where is the problem. Whether the problem is with the testes or with the higher level, that is the pre-testicular, testicular or the post-testicular. So we do the test of FSH and testosterone. And do we do the genetic testing? No, genetic testing is only done when they have men with necrosomia and oligoasterospermia. That means there are dead sperms there, and always a low count is there, less than 5 million, then only we go for genetic testing. And then when we do the gene mutation test? Only when there is congenital bilateral absence of the VAR preference. And by Y-chromosome microdeletion is when they have multiple abortions or they have a severe oligospermia. What test we do? For our basic practice, total is more than enough. Transrectal ultrasound or abdominal ultrasound, these are for completion. But for us, as a practicing agent, if you see a low count, you always ask the male partner to do repeat the sperm. Again it is low, then you ask them to do a FSH and a testosterone along with an ultrasound. Okay, and this is the basic test which we do. Along, if we find any problem there, we can refer to an andrologist to see, or a male gynecologist where they will be more comfortable to be examined and tested. And the ultrasound, what does it say for us? We can pick up varicocele. Varicocele increases the temperature of the testes and reduces the count. And this is how we do it. I know the color Doppler will show increased vascularity of the testes. And many a times varicocelectomy done increases the count, but that is very short time, and the female has to conceive immediately after, because again the varicocele reappear and the count goes down. Sorry, I am not able to move my slides.
Yes, ma'am.
Now coming to the then now we come to the last, the testicular biopsy. Do we do? Yes, we do only when we see the total count is very less. We can do it as a diagnostic or a therapeutic, which is not required for you, just for completion I told that. Now, sperm needed for fertilization. You remember how much the sperm is required? Very less. It is only 15 million required for the natural conception to occur. And if you've got between 10 to 15, we can go for IUI. And if you've got around 50,000 or less, then we go for the IVF. And if you've got very less, that is less than 10 sperm, 10,000 sperm, then we can go for the ICSI, that is intracytoplasmic sperm injection, which is done now, that is each sperm is taken and injected into the wall of the ovum. Now coming in short about the assisted reproductive technique, it has been explored in the last decade. Everyone going for the ART. ART incidence is increasing because of the late marriage, conceiving late, lot of other issues are there, and what does it do? It helps the infertile couple with the tools to bypass the normal mechanism of gamete transposition. Okay, and the take-home baby, we cannot look doctor and then spend 2 lakhs on ART. Can I go for the ART and can I conceive on that? Because I don't have time, I want immediate pregnancy. Remember that the live take-home birth is only 25%, which can be achieved with IUI also and natural conception also. So all the couples should not be encouraged to go to ART directly. Only when they have poor result or the count is less or any problem is there, then only we ask them to take. Because the reason I showed this slide is take-home baby is only 25%. So it is not that everybody will conceive with ART. Okay, and it also depends upon the age of the person. Now we have IUI. Now what is IUI? IUI is a type of artificial insemination, a procedure for treating infertility. Now what do we do? We give the lady ovulation induction tablets and we see that she is ovulating. Once around the ovulation, before we give a trigger of human coronary gonadotropin, we take the sperms, and these sperms are washed and concentrated and placed in the uterus directly around the time that the ovary is released. Okay, it is an OPD procedure, not a very big procedure, very cost effective also, and this is the time when we have which people will do IUI when they are unexplained variety of infertility, where we have found that the tubes are okay, ovaries are okay, she is ovulating, husband count is okay. Another indication is when the count is less than 15 million, where they are not able to conceive on their own, but it is definitely more than 10 million. If it is less than 10 million, IUI will not work. We have to go for either ART, IVF or with ICSI we have to go. So if the count is between 10 to 15 million, we can go for IUI, and minimum of 6 cycles of IUI is done to say that it has not worked. The hope for outcome of IUI is the sperm. What do we do? That the sperm will swim up the fallopian tube and fertilize their waiting egg, that is around the ovulation, resulting in the normal pregnancy. So the most common reason for IUI, as I told you, is when the sperm count is less, and when we have unexplained infertility, hostile cervical condition is there, and when we have the ejaculatory dysfunction, where there is the male is not able to erectile problems he has, then we can collect the sperm and then do the IUI. So the main indication for IUI is when there is diffuse sperm count, or when there is unexplained infertility, and when there is a ejaculatory dysfunction, or when there is a cervical scar is there. She has got a previous what we call the cervical thing done, or any large loop excision of the transformation zone is done, or any cervical surgeries have been done, where the sperms hinder the ability, or then when they have got the Purandarese, when they have got the Fothergill surgery done, where we remove the cervix and all that, in those conditions only the IUI will be held. It is not recommended for female who have got tubal function, because the ovum has to come there. If they have problem with the tubes, IUI will not occur. We have history of pelvic infection or the endometriosis. Now why in endometriosis it won't work? Because the tubes will be in the correct position, they will be fertile and motile. The ovaries will be stuck to the pouch of Douglas. So the ovum pickup is very bad in case of severe degree of endometriosis. How does IUI work? Before the IUI, ovulation should be, as I told you, by giving the ovulation induction tablets, and to determine that the egg is mature, IUI procedure is performed 24 to 36 hours after the LS surge, and it indicates ovulation will occur soon. So just before the ovulation is the right time to do the IUI. The semen sample should be washed in the lab and collected in the cell lab, catheter is inserted into and given into the uterus directly, and this, what does it do? It maximizes the number of sperm cells that are present in the uterus and increases the possibility of conception, and it takes only a few minutes, and it watches for the signs and symptoms of pregnancy after that. IUI success rate is around 20% per cycle, means out of the 100 people who have done IUI, 20 people will conceive. Same as IVF. So you understand, 20 to 25. So the success rate does not change. It is just individualization of the people and individualization of the couple which procedure to be gone for. So when IUI is less expensive and less invasive, pregnancy rates are lower than that from the IVF as it is always it is less expensive, and then you can go from the 25% with the IVF. Conclusion slide is always choosing the right patient couple. You have to do right investigation, follow the right protocol. Then only you will have the success for the treatment for infertility. That is the goal of success. Thank you. Thank you very much for giving me the opportunity. Can you hear me? Can you hear me?
Thank you so much, ma'am. Thank you so much for the session. Ma'am, on small we'll be having a question and answer session. So
sure.
Students, if you have any doubts or any question which you want to ask to ma'am, you can post it in the chat box. We will read it to ma'am. So I repeat, students and interns, if you have any doubts related to the topic or any doubts related to the session which ma'am has taken right now, kindly post your questions in the chat box. We'll read it to ma'am.
You can even tell any silly doubts also, no problem.
So ma'am has given permission for that also. So even though it is going to be a silly doubt or a blunder, you can ask it.
Don't worry at all.
Yeah, ma'am, one student has asked, name is S. Harini. She has asked that what is the general management we can give for couple with unexplained infertility?
Yeah, listen, unexplained infertility will come only when you have done the whole investigation. We have done everything. We have seen the uterus, we have seen the tubes, we have seen that they have tried enough, different types of treatment has been tried to them. Then only we come to the conclusion of unexplained infertility. Now what investigation, as I already told you, unexplained infertility, we always go for IUI. If IUI 6 cycles does not work, or if they are elderly couple, then definitely we have to go for IVF or ART procedure.
Ma'am, the next question is, what about the diet management? Diet management for infertility cases, ma'am.
See, diet management diet has got nothing to do with infertility. Okay, unless the lady is obese, okay, and she's put on lot of weight. In that condition, we have to go on strict diet. Strict diet means what? Not to stay hungry. She has to take small, frequent meals and cut down whatever she is eating to have. Okay, suppose she is eating, usually what happens, they think that they will diet, so they will go for fasting for a long time, and directly they will have lunch at 1 o'clock, 2 o'clock, and then, 2 o'clock and not eaten anything, and then they go for a late night dinner. Always remember breakfast. Breakfast is breaking the overnight fast. We should always have an early fast, early breakfast, and it should be divided, the meal has to be divided into 6 meals. Morning 7:30 egg breakfast, 9:30 time some fruit or some buttermilk, afternoon rice, little bit of rice, whatever you are eating, you have to reduce it to half. Then in the 4:35 some healthy homemade snacks like something like sundal or a fruit, and early dinner. We don't have late dinner. Okay, so early dinner by 7:38, and night she can drink a cup of milk or something. So what she is eating, she has to reduce it to half, and that half she has to divide into small frequent meals. Okay, this is what we tell them. Apart from the diet, she has to work on to burn her calories she has already gained. So there is no particular diet for any person. You can't tell this is the diet for you. You have to sit and see. You have to talk to her and find out what is the diet she is usually taking, and whether she is a vegetarian, non-vegetarian, working, whether she is cooking at home, eating from outside. So you have to sit and prioritize and see exactly what it is, and accordingly give her the dietary advice. Diet per se does not cause infertility. It is the gain weight which causes the anovulatory cycle because of the fat around the tummy, which converts the female hormone to male hormone and causes the anovulation. That is how the diet comes into that picture. Per se, diet does not have any role in infertility.
Okay, ma'am. Now the next question is there any saying that OCP, oral contraceptive pill, is going to cause infertility in the long run.
No. The other is the opposite. So what we do, people think that if I take the oral contraceptive pill, what will happen? No. We use it for down regulation in case of polycystic ovary when the LH is very high. Normally what happens in the first half of the cycle, FSH is high, and after around the time of ovulation, the LH is high. But in case of polycystic ovary, the FSH-LH ratio is altered on the day 2 or day 3 of the cycle, and the LH value is very high. So what do we do? OCPs rather causes a good chance of ovulation. When we give them oral contraceptive pills, 1 or 2 cycles of irregular cycles, then what happens? It suppresses the hormones in the body. And so what happens after 2 or 3 cycles of ovulation of oral contraceptive, when you leave them, spontaneous ovulation occurs. So it is a myth that that OCP causes infertility. It does not cause. Rather, if she got irregular cycle, it has got a very good impact. So when the couple comes to us with irregular cycles, we try to regularize the cycle by giving the OCP. So always make it clear to them that I am not giving the tablet to prevent ovulation, because on the pamphlet it is written that this is for contraception. I am giving you to regularize the hormones, so to regularize your cycle, so that the LH value comes down, so that you have a good ovulation after that, and the what we call the ovulation induction tablets like Serum and Estradiol work better, and even spontaneous ovulation also occurs. So you see, newly married people, they would have taken OCP for 1 year, and suddenly when they stop, the first 2 cycles is very ovulation on its own, so they will conceive on its own. So it is a myth to think about it. Okay.
Ma'am, one question, ma'am. Can you please throw light on endometriosis with infertility?
Yeah, now endometriosis, what happens? It is endometriosis means that there is the endometrium which is present inside the lining of the uterus is present elsewhere. And the most common site of endometriosis is the ovaries, where you get the chocolate cyst. Now what happens in that? When the chocolate cyst is there, it keeps on increasing in size. The lining of the endometrium which is present in the cavity is also present in there. But normally when there is shedding of the endometrium, the menstrual blood comes out. But when it is present in the ovaries, or it is present in the uterosacral ligaments, or in the other side, which is not able to come out. So what happens? What tissue reaction it causes? The blood keeps on collecting and forms the endometriotic cyst. Similarly, in the pouch of Douglas and uterosacral ligament, it causes fibrosis. So when there is a blood in the tissues, it causes fibrosis. So when there is fibrosis, the ovaries go and get attached to the pouch of Douglas. Okay, so when there is an initial grade of endometriosis, you may not see the big endometriotic cyst there, but the ovaries will be stuck to the pouch of Douglas. But the tubes remain in its correct position, that is up. So when the tubes are up and the ovaries are down, the ovum pickup does not occur. So that leads to infertility. Moreover, when the endometriotic cyst is there, it damages the rest of the ovarian tissue, causing pressure, and sometimes the whole of the ovary is replaced by the endometriotic cyst, and we get a very less ovarian tissue left. So in these ways, endometriosis causes infertility. Sometimes there will be dyspareunia, so they will not be able to have contact. That also leads to infertility in case of endometriosis. And sometimes ovulation does not occur in endometriosis because of the high level of estrogen level. It's a hyperestrogenic state. So they may not be. So there are multiple factors in endometriosis which leads to infertility, beginning from the tubo-ovarian anatomy, to the follicles getting damaged by the endometriotic cyst, to the dyspareunia, to the what we call the uterosacral ligament stuck, to the ovum pickup hampered by the endometriotic cells and endometriotic tissue. So a lot of factors are there which causes infertility with endometriosis.
Thank you, ma'am.
The next question is, what are the chances of a female getting pregnant if there is unilateral tubal block?
Yeah, unilateral tubal block is not a big issue, because sometimes what happens when we do ectopic pregnancy and we remove the tube for the female, salpingectomy will come out. The first question comes that can I conceive with the other tube? As we are reading anatomy, ovulation does not occur in the same ovary every month. It can occur in alternate ovaries. And there has been seen that there is a chances of transimonic the ovum going to the other tube and conceiving also. So, but you should be sure that the other tube, which is normal, is having good motility, because sometimes what will happen when you do the HSG, the motility will be seen, but the endothelial lining may be disturbed. So with a good one tube, there are good chances of conceiving. It is not very much reduced, because as you know, normally itself with the two tubes, only one tube helps in ovulation, in conceiving. Both the tubes are not required per cycle. Okay, so don't get worried. If she has one tube, definitely she can conceive, if there are no other factors of infertility associated with it.
Okay, ma'am. And through the processes like IVF, ICSI and all, and the female is conceiving, is there any chances of defects in the baby through those methods?
We have seen that the chances of IVF babies having anomalies with the babies is comparatively higher than the normal conception. That is seen. That is a known fact. That's a known fact. So, and especially when they have the family histories, we have got people with family history of lot of congenital anomalies. So what we do in such case, we do the genetic karyotyping of both the males and the females before going. That is something called pre-implantation karyotyping of the ovum. It can be done. This is not routinely done. This is usually done with the family history of having some congenital anomalies going on in the family, very rare diseases are there, and those condition only those, but definitely IVF baby have more chances, because the artificial method. So we don't know where what goes wrong. So there is more chances of babies having anomalies in case of IVF baby. That is a known fact.
Okay, ma'am. What are the chances of conception in a retroverted uterus, ma'am?
See, retroverted uterus per se does not reduce the chance of infertility, provided it is not stuck to the pouch of Douglas and the tubes and ovaries are normal. They have also gone retroverted. The only thing we advise the couple is after being together, come and lie down on the tummy. That is the only thing we advise. Retroverted uterus per se is normally present in 30 to 50% of the people, but acutely retroverted. When it is totally retroverted, which we can find out on the scan, always remember that we have to see whether it has got endometriosis or not, and the tube is fine or not. And sometimes IUI may be required under ultrasound guidance to correctly direct the fluid to go into the correct direction. But as per se, retroverted uterus normally which is present, some degree of retroversion is there for all females, will not cause infertility. Because only the acutely retroverted uterus will cause infertility if it is stuck to the uterus and the tubal ovarian anastomosis is not correct. And if the tubes are fine, we can definitely go for an IUI with an ultrasound guidance to know the correct way to insert the semen.
Okay, ma'am. We'll just wind up with the last one question. Kindly throw some light on surrogacy and non-detention of semen.
Now surrogacy has come in a big way, and India being a poor country, lots of people from the West keep on coming to us, and they want to have the baby, because this is usually indicated. Ideally, it is indicated in the female with von Rokitansky syndrome, where they do not have the uterus on their own, or in the female who has had a previous hysterectomy done, or in a female where they have where their uterus is not able to hold the pregnancy. So in those cases, surrogacy is done. Surrogacy can be done with her own, it can be done with her own ovum. Okay, if she's got ovaries there, or she's got previously reserved that ovary is there, or it can be done when you can take an ovum donation. When do we do here? We can take hers ovum, or we can take totally donor's ovum. It can be a sister, it can be an unknown donor, and it can be the husband's sperm, or it can be a totally old couple, they don't have, both of them are not there, so we can go for a both donor embryo. What do? We hire a female. Okay, that female is totally investigated and found out that she is not having any problems, and her karyotyping, everything is done, and the family history is there, and her family is allowing her to go for surrogacy. Okay, that is very important. Many a times the female is not having the family support, and very lot of issues come in. Both the person, that is the person who is the surrogate mother, and the person who is carrying it, or the what they call the biological mother. Biological mother is the mother whose ovum is taken, or who is giving the permission for surrogacy, and surrogate mother is the mother who is carrying the baby. She undergoes the IVF, and she undergoes the IVF and carries the baby for her. And in that situation, they have a lot of legal documents are signed between them, and then she guarantees that she will be giving back the baby to her. And there are also legal laws whether she will allow the feeding or not, whether the feeding will be breastfeeding or feeding will be by giving the artificial feeding to the baby. So a lot of rules are there. And after the baby is born, it is the right of the biological mother whether she will allow the baby to be seen by the surrogate mother, not seen by the surrogate mother. It is totally in her thing. Usually they will not allow. And nowadays the surrogacy has come with single parents. I had last year one mother who did not want to get married, but she wanted to have her own baby. So she got her surrogacy done. And that she was a single mother. She got the surrogacy done. She used to come for the checkups for the female, and that female already had 2 children. She got surrogacy. When I questioned her, it was only for monetary interest. And the amount I really don't know, but probably a huge amount for her to take care of her other 2 children. And towards the end, she stayed with the biological mother, delivered with us, and then soon the mother was kept separately, and she used to only use the breast pump to give the mother to the baby, and after 1.5 months she was sent back to the home. So surrogacy has come in a big way, and it is usually a very costly affair, and it has been also misused by people, the actresses and other people who don't want to have their own baby, don't want to spoil their figure at all. But the rules are very strict now, okay, and it has to come in a long way, and usually the surrogate mother generally should be a mother or a sister, but usually we always hire the person with a low economic status and go ahead with it.
Ma'am, regarding the semen retention, ma'am.
No, I am not able to understand what does the semen retention means. What are you hinting at?
Ma'am, generally they say that infertility can be due to non-retention of semen.
Can be
like that? Infertility can be because of non-retention of semen. Is it so?
No. There is nothing like non-retention of semen. See, once they have an intercourse, the semen goes into the vagina. Okay. So only the few active sperm within a matter of few seconds goes into the tube. You understand? Okay. And the female feels that after intercourse it comes out. That is normal. The liquefaction time is there 20 minutes. It will definitely come out. It is the sperm which climbs up. Did you understand? Okay. The female have a long misnomer that the sperm comes out. It is a present state. That is a wrong thing. Okay, if it is the correct intercourse, it just ejects onto the cervical canal. Okay, it just goes into the cervical canal. Matter of few seconds, the active sperm or the sperm just goes into the tube and fertilizes it. Okay, and the rest of the fluid is the prostatic fluid, the seminal fluid. It helps the sperm for nutrition, the fructose and all that, gives the proteolytic enzymes so that it does not clot when it is released. Okay, does not coagulate when it is released, and helps. So that is a misnomer. There is nothing called non-retention of semen into the vaginal canal. That is what I understood. I have not heard of this word before.
Okay, ma'am. Thank you, ma'am. And with this, we end the questionnaire session. Now I request our HOD, Dr. Anuradha ma'am, to give the oath of thanks for Dr. Preet ma'am. Am I audible?
Yes, ma'am, you are audible, ma'am, but I am not able to see. I think my video is blocked. So now I am able to see.
The video is... Are videos visible?
No, ma'am, it is not visible.
Yes, ma'am, it's visible now, ma'am.
Visible, huh?
No, I am not able to see.
Yeah, yes, ma'am.
My video is, but I am not able to see the rest. No problem.
Still loading in it.
Ma'am, you are actually visible, ma'am.
Okay, no problem, but I am not able to see. No problem.
Yeah.
Thank you for this wonderful session, ma'am. Really, people will say if you cross obstacles, you will have very good destination. Like this, starting up the program, we do ads and obstacles, but seriously, the session is really wonderful, ma'am. You really explained from the basics for the first year students till the doctors who are practicing. Everything is crystal clear, and really appreciate that you covered the anatomy, physiology, pathology, and the lab investigations, and even the treatment part. And now you answered for the diet and regimen and management part also. It's really impressive and worth, ma'am, really. And we really appreciate you for the valuable time you spend in your busy schedule. And on behalf of my management and my staff and my students, I really thank you for this wonderful session. Thank you, ma'am.
Thank you, ma'am, because I was not sure about the crowd. I have never spoken to a homeopathic students. So I myself was not sure exactly what to put on the slide and what can be done. I hope I have just done justice to the huge topic. So thank you once for all of you. Thank you very much for inviting me. Special thanks to Purnima. She's my patient, so she knows about me. So thanks for allowing me to come and speak to all of you. Thank you very much.
Thank you, ma'am. That was a great pleasure having you, ma'am. Thank you so much. And we see to many more sessions with you, ma'am. We would like to have. Whenever
thank
you're
you,
free.
thank you. Sure, dear. Thank you so much. And thank you to HOD ma'am. And now I can see her. Yes, I remember her very well now. Okay, she is my Marina's patient sister-in-law, so definitely I remember you. Now it's very clear. Yeah.
Thanks so kind of you, ma'am.
Thank you very much.
Now I request Anuradha ma'am to carry over for the next section, where she'll be talking about homeopathic therapeutics in infertility. Over to you, Anuradha ma'am.
Yes, ma'am. Yeah. Good afternoon, everyone. Am I audible?
Ma'am, you are audible,
yes,
but your PowerPoint is not visible, ma'am.
No, I have to share. I have to share. Still loading.
இந்த கொடுத்துருங்க வரதுன்னு Yeah, your screen is visible, ma'am. Kindly switch on to the presenter view.
It's still loading in my computer.
Okay, ma'am.
Is my screen is visible? PPT is visible?
Yeah, your screen is visible. Ma'am, your PPT is visible. Kindly minimize the free conference call app and switch to the presenter view.
Yes. It's still loading. Yeah. Is it okay now?
Yeah. Ma'am, switch it on to the presenter view, ma'am. The slideshow.
How to?
On the normal way how you do a presentation. Yeah, the normal way how you present a PPT, ma'am. Click on the slideshow option.
In my screen, nothing is coming. For you people, the screen is visible, huh?
Yeah, screen is visible, ma'am, but still the PowerPoints are in a the slide view is only visible, ma'am. The whole screen is not. You have not changed it to the whole screen.
Fine. Now?
No, ma'am. Give the slideshow option, ma'am.
Slideshow option. One second.
Yeah, from beginning.
From where?
In the left top corner, you have a option called from beginning.
Acha, fine.
Yeah.
Is it visible now?
Yeah, it's clear now, ma'am. You can continue.
So I can proceed.
Yes, ma'am.
Okay. Sure. Good afternoon, everyone. And as Dr. Preet ma'am discussed about the infertility in detail in both the sexes and the physiology, anatomy, and pathological part, let's enter into the therapeutic part. Homeopathic therapeutics on